for the brilliant presentation. Our next talk is on testosterone supplement controversies. To deliver this presentation, I invite Dr. Mahmood Hassan, consultant endocrinologist, Dhaka Medical College Hospital. Dr. Mahmood Hassan, please.
Thank you, moderator, for your warm introduction. Respected chairpersons and learned audience, Assalamu alaikum and good evening. Welcome you all to today's session on recent controversial issues in testosterone replacement therapy. So these are the session overview that I will highlight during my session. Let us begin with a clinical scenario. A 66-year-old man with fatigue and low libido whose morning total testosterone was 8.3 nanomole per liter and repeat total testosterone was 8.1. BMI was 36 kg per meter square and he was on opioid for back pain. So what should you do next? Whether we start testosterone replacement therapy now or whether don't start or whether optimize reversible factors and recheck after intervention. Let us see. There are some opinions that are similar across all subspecialty about the testosterone use in older age, like no routine screening for older men, diagnosis needs symptoms plus too low morning testosterone, and exclusion of reversible causes and consideration of lifestyle is advised by all. So what is the view of endocrinologist? These are the same like the previous slides, and the only exception is that the use cutoff value, the many endocrinologists use at less than 9.2 nanomole per liter as the cutoff value for low serum testosterone, and gel formulation is the preferred method. So what does the urologist think about that? American Urological Association, they set the cutoff point as 10.4 nanomole per liter, and they also advise screening in high risk cases even without the symptoms of hypogonadism, that is patient with unexplained anemia, diabetes and osteoporosis, while the European Association of Urology cutoff value is less than 12 nanomole per liter. The American College of Physicians guidelines state that they don't recommend testosterone therapy to only improve sexual function. They recommend to only improve the sexual function, not to improve the energy, vitality or cognitive function. And they recommend that if there is no improvement after 12 months of use of testosterone, stop it. And IM formulation was preferred by them for low cost. So the British Society of Sexual Medicine, they say that start testosterone therapy if the total testosterone is less than 8 plus patient having symptoms. While if the testosterone value is 8 to less than 12 plus symptoms, you can start testosterone replacement therapy for trial at least 6 months. And if there is no improvement, you can discontinue. If there is improvement, you can continue. So they also set a cutoff value on free testosterone level less than 0.225. So what should you do? We should ask the patient about the classical symptoms of hypogonadism, present or not. We should measure at least 2 morning total testosterone, and if there is any problem in the sex hormone binding globulin, we should measure the free testosterone, and we should fix the reversible causes like opioid obesity and acute illness, and we should reevaluate after treating the reversible causes. The next section is testosterone replacement therapy and cardiovascular safety. The recent Travers et al. Found that testosterone replacement therapy was non-inferior to placebo for major adverse cardiovascular event. And based on this finding, FDA changed their approval warning levels for cardiovascular safety on testosterone in 2025. But there was slightly higher incidence of atrial fibrillation and pulmonary embolism. So the next section is whether controversy about the TAT and bone health. Many studies showed that testosterone increased bone density in hypogonadal men. Testosterone trials which involved older men with hypogonadism, the TAT for 1 year increased the volumetric bone mineral density and estimated bone strength on quantitativity. So the debate is whether testosterone can reduce fracture in hypogonadal men. Let us see what the data say. The Travers study found higher fracture risk with testosterone group than placebo. These findings contradicts the earlier study findings. So in summary, testosterone alone cannot reduce the fracture. If there is in hypogonadal patient with osteoporosis, we must give osteoporotic medication along with testosterone. The next section is hemoglobin A1C reduction and testosterone therapy. 40% patients persons with diabetes have low testosterone who have poor quality of life and sexual health and poor glycemic control. So the debate, can testosterone replacement therapy be used in type 2 diabetes person with low testosterone for improving glycemic control, or whether it can be used in pre-diabetic patient for prevention the progression to type 2 diabetes. A long-term Germany study of 11 years observed that men with type 2 diabetes mellitus with hypogonadism getting testosterone had progressive and sustained reduction in fasting blood sugar, hemoglobin A1C and HOMA-IR. And the 34% men on testosterone therapy achieved diabetic remission, and around 47% patient achieved normal glucose regulation. So the recent ABCD testosterone and diabetic audit 2025, which occurred in 10 countries and 40 clinics, showed that the hemoglobin A1C reduced from 8.6% to 8.1% and 7.8% and 6.9% in 6 months, 1 year and 3 years after testosterone replacement therapy. And there was also improvement of symptoms of hypogonadism. Another study of 2 years follow-up study, T4DM study, showed that 41% reduction of diabetic incidence in testosterone and lifestyle treated group than the placebo and lifestyle group. And no serious adverse effect were found between the two groups. So in summary, no TRT2s improved the hemoglobin A1C in diabetes mellitus patient with asymptomatic men. The next debate is oral testosterone, whether we should use it or not. We know there are some drawbacks of oral formulation like inconsistent absorption, multiple daily dosing, it should be taken with food, and liver toxicity and fluctuation in the blood testosterone level. So what does the recent insights? The recent phase 3 trial of 315 patients shows that 87% patient with oral testosterone getting oral testosterone 225 milligram BD achieved testosterone concentration within normal range, and there was significant improvement of sexual function and libido in the oral testosterone treated group, and no death or liver toxicity were found in the oral treated group. So study by La Vinera showed that the obese men with metabolic hypogonadism were treated into 3 groups, one with tirzepatide, another with diet only, and another with testosterone. And the group treated with tirzepatide showed greater weight loss and improved international index of erectile function and the gonadotropins and testosterone and free testosterone level at 2 months. So, does tirzepatide alone can be used in metabolic hypogonadism? The drawbacks are there are no study of tirzepatide on sperm parameters is still available, no long-term data of tirzepatide on improving hypogonadism alone, and direct drug-specific effects of tirzepatide not established yet, and tirzepatide is not a substitute for testosterone replacement therapy in classic organic hypogonadism. So the last section is prostate cancer and testosterone therapy. A 60-year-old man with symptomatic late onset hypogonadism who was treated localized prostate cancer 12 months ago. Now his PSA is undetectable. Whether we should treat the patient or not. The concern in these cases is the chance of recurrence, when to start the testosterone replacement therapy, and the follow-up schedule. Let us see what the data shows. And the recent TRAVERS trial, it is no evidence of increasing prostate cancer found by testosterone replacement group, and the patient who undergo radical prostatectomy or radiation therapy and who have undetectable PSA, those who are placed with the testosterone replacement therapy, they maintained the undetectable PSA level with no evidence of recurrence. So in this group of patients, selected group of patients, TRT can be used. So what action should be, cautions we should take in this group of patients? The TRT can be started after 1 year post-surgery or radiation therapy, not before that. And there should be close monitoring of PSA level, that is 3 monthly for the first year and 6 monthly thereafter. And even in high-risk cases, the frequency can be more, and stop the testosterone replacement therapy if PSA level is more than 2.2 nanomole per liter and reevaluate the case. So the take-home message is no routine screening for testosterone for asymptomatic older age population. Testosterone replacement therapy only when the classical symptoms and repeated testosterone value. Osteoporotic medication should be given in hypogonadal patient for fracture risk reduction. In symptomatic men with hypogonadism, TRT along with lifestyle can improve the HbA1c. Still, testosterone gel or injection are the preferred choice by the endocrinologist due to long-term lack of safety data of the oral testosterone, and tirzepatide may be a future game changer besides testosterone replacement therapy in patients with metabolic hypogonadism. And TRT can be given in selected treated prostate cancer patient with close monitoring and sharing the risk factor to the patient. Thank you all for patient sharing. Thank you.